Good morning to all. Today we are going to see the important topic, that is an uterine prolapse. As a female people, we are having so many health issues. Among us, the important one will be the uterine prolapse. So prolapse means changes from its original position. So first you will see that introduction, sir. So it is a common condition that may happen irrespective of any female at any age. So the common causes will be the multiple vaginal births. Here the muscles and the ligaments will become loosened around the uterus. That leads to the weakened uterine muscle. So when these support structures starts to fail, the uterus will sag out of its normal position. So the treatment of the uterine prolapse involves surgical and non-surgical options based on the severity of prolapse. So it is a most often most of the female, and then it is one of the form of the herniation. Uterine prolapse can happen to women of any age, but it affects both menopausal women who had one or more vaginal deliveries. The incidence of the prolapse is about 1 in 250 pregnancies. So if you're seeing the definitions, it is a medical conditions where an organ or the tissue falls out of its place, that is in original position, or slips down. So uterine prolapse is a conditions where the muscles and the tissues around the uterus will become very weak. That will cause the uterus to sag or drop down into the vagina. So uterine prolapse is also known as in descendants or prosidentia. It is a type of a pelvic organ prolapse of the uterus which takes place in the womb. So here this picture will show the normal uterus and the prolapsed uterus. So here the normal picture, we can see that the normal position of the uterus. And then here you can see that the uterus will prolapse. It descends into the vaginal area. So the risk factors, if you are seeing, having one or more vaginal births, being older when you have the first baby, and then giving birth to a large baby, and then aging, and then old age, obesity, and prior of pelvic surgery, chronic constipations are often straining during the bowel movements. And then any family history of weakened connective tissue, and then being a Hispanic or white region people, then chronic cough such as a form of smoking. So the common causes of uterine prolapse, frequent vaginal birth, and then menopause, and those who are doing a very hard work, and then family history of the uterine prolapse. So in detail, if you are seeing that causes, that is, in birth injury is the important causes. A perineal tear is less harmful than the excessive stretching of the pelvic floor muscles and the ligaments that occur during the childbirth, because overstretching causes atonicity, whereas the torn muscles could be stitched or torn up. Then following that, the next causes will be the peripheral nerve injury, such as an pudendal nerve injury during a childbirth causes the prolapse, which is reversible in 60%, and it may be responsible for stress incontinence also. So along with that previous one, the next important causes will be the bear down, that is the unnecessary force during the before full dilatation of the cervix during the labor when the bladder is not empty. That will lead to the prolapse of the uterus. Heavy work just after the delivery without any rest or pelvic floor exercise also will provoke these conditions. Then delivery of the big baby macrocephaly will also structure the perineal muscles and lead to a patellus, introitus, and prolapse. So precipitate labor and fundal pressure also responsible for this uterine prolapse. And then rapid cessation of the pregnancy will add the prolapse. Then loss of the pelvic support, which results in the uterine prolapse. Then postpartum cough, all this will lead to the uterine prolapse. Then other causes, if you are seeing, congenital weakness, that is the most important causative factor of the uterovaginal prolapse is in the nulliparous women. Then acute defects, multiparous women, overstretching of the ligaments. Then menopausal atrophy, that is in withdrawal of the estrogen. There is the atrophy of the genital tract and its supports in a woman due to atrophy of the ligamentous supports of the uterus, and vaginal prolapse will develop. Then activating factors. The uterine vaginal prolapse is aggravated by following the two factors. That is small fibroids attraction on the uterus, then pelvic tumors. So these will provide more pressure in the uterus. That also will lead to the prolapse. Then body type. Some women will have the softer connective tissues than others. That means the ligaments that support the pelvic organs loosen more easily. So that case also they are more prone to stretch during the pregnancy and the childbirth. So there may be a higher risk for developing the prolapse. Then obesity. So it is very important for all the females. They have to be very cautious in maintaining the normal BMI. So obesity is a main responsible factor for most of the health issues in the current scenario. Then pathophysiology, if you are seeing here, that is a displacement or prolapse of the uterus, bladder, and the rectum can be a congenital or an acute condition. So congenital tilting or flexion of the uterus is a rare condition. More commonly, tilting or flexion disorders in which the uterus remains within the pelvic cavity are related to the scarring and inflammation of the pelvic inflammatory diseases, then endometriosis, pregnancy, and the tumor. So here during this condition, they'll be using a excessive force, or these tumors will give the excessive pressure to the uterus that lead to the prolapse of the uterus. So downward displacement of the pelvic organ into the vagina, especially it results from the weakened pelvic musculature, is the main first and foremost causes. And another thing, due to the obstetric procedures that lead to the unrepaired lacerations, from that one we'll be seeing detailing. That is a weakened pelvic musculatures. It includes stretching of the supporting ligaments and the muscles during the pregnancy and the childbirth. Will be following that. Unrepaired laceration from the operative procedures like the childbirth, rapid deliveries, multiple pregnancies, congenital weakness associated with the mother condition, then loss of elasticity and the muscle tone with this aging. All this will lead to the prolapse, pelvic organ prolapse, that lead to the abnormal conditions. Then types of the prolapse, if you are seeing here, that is an uterovaginal prolapse. So here the name itself, we will come to know that vagina and the uterus and the cervix and the upper vagina is the commonest one. So it is accompanied by the cystocele. So next will be the congenital prolapse. So here no cystocele, but often seen in the nulliparous, so called as a nulliparous prolapse. It causes the congenital weakness supports of the uterus. So here these four pictures shows the abnormality of the uterus condition. First will be the without a prolapse, that is a normal one. Then here the shows that the cystocele or cysto-urethrosis, this arrow mark shows. Then this is the rectocele. Then this will be the uterine prolapse. So the arrow mark will be showing the abnormality, that uterine prolapse. Then enterocele, then vaginal wall prolapse. So here you can see that the part of the intestine organ, and this will be the vaginal wall prolapse. All this picture will shows the prolapse. Then following the classification of the prolapse, anterior vaginal wall prolapse, then posterior vaginal wall prolapse. So anterior vaginal wall, upper 2/3 cystocele and the lower 1/3 will be the urethrosil that lead to cysto-urethrosil. Then posterior vaginal wall, upper 1/3 enterocele, then lower 2/3 rectocele, pouch of ductus hernia. Then uterine descent, that is based on the degree, first degree, second degree, and third degree will be categorized. First degree will be the descent of the cervix in the vagina. Second degree will be the descent of the cervix into the introitus. Third degree will be the descent of the cervix outside the introitus. Then the final will be the procedentia, that is the entire uterus will be outside the introitus. That is shows in the picture detailing. That is the normal uterus. Then first degree, you can see that the prolapse, that is cervix in that vagina. Then second degree, the cervix descent into that introitus. Then third degree will be the descent of the cervix outside. This arrow, this line will shows. Then procedentia means that is a entire uterus will be the introitus. So degree of the prolapse we can see detailing. First degree, the uterus descends down from its anatomical position. External os at the level of ischial spine, but the external os still remains inside the vagina. Then second degree, the external os protrudes outside the vagina, introitus, but the internal body still remains inside the vagina. Then third degree, the uterine cervix and the body descends to lie outside the introitus. It is known as a procedentia or complete prolapse. Then procedentia means prolapse of the uterus with the eversion of the entire vagina. It is inevitably associated with the cystocele and enterocele. This condition is provide a more discomfort for the female. So this is a detailed picture of the uterine descent in the degree form that we discussed in detail in the previous slide. So I'm skipping this one. Then investigations, hematology. Then specifically rectal and pelvic exam, vaginal, like these 3 exams will be carried out to know where the prolapses occur properly. Then ultrasound to know about the detailed picture of the prolapse. Then X-ray and MRI. MRI will be not advised for usually not advised. In advanced cases, it will be advised. The signs and symptoms, uterovaginal prolapse may be visible during the inspection of the vulva. So in case of the minor prolapse, it may be visible on the staining. Rectal examination also will differentiate between the rectocele and enterocele. So feeling of something where coming down from vagina, that especially the female will be complaining of discomfort while on walking. Then backache or dragging pain in the pelvic area will be associated. Then dyspareunia will be the urinary symptoms like in presence of the cystocele, difficulty in passing the urine, elevate the anterior vaginal wall for bladder evacuations. The incomplete evacuations will lead to frequent desire to pass the urine. Urgency and the frequency of the micturition also may be due to cystitis. Then painful micturition is mainly due to the infection. Stress incontinence is usually associated due to erythrocyte, and retention of the urine also will be associated. The management, if you are seeing, that is especially first one will be the preventive measures we have to take out to prevent this condition. Then follow that physiotherapy, pessary, and the surgical treatment. We will be discussing detailing one by one. Preventive measures, if you are seeing here, first one will be the repeated childbirth with short intervals cause the UV prolapse. So women should be advised to avoid frequent pregnancies in quick succession of the labor should be emphasized. Should be emphasized. Then first stage, avoid unnecessary bearing down. Breech or forceps delivery before full dilatation of the cervix should not be attempted. In second stage, avoid prolongation of the second stage. That also will lead to the excessive pressure and lead to the prolapse. Then perform episiotomy if there is any tear or overstretching of the perineum. If then third stage will be the avoid grid method. Nowadays we are not using this grid method. Then episiotomy or tear should be carefully sutured. That is an important one. If you are not doing that one, that also will lead to the weakened musculature and prolapse will be taking place. Puerperium, treat chronic cough and the constipation. Avoid strenuous exercise and standing for the prolonged time to be done. That means we have to advise that avoid standing for a prolonged time. Then follow that physiotherapy is the next treatment. That is early case of the uterovaginal prolapse are helped by the pelvic floor exercises, particularly during the puerperium and while waiting to undergo the surgical treatment. Then Kegel's exercises are used to tone up the pelvic musculature. So these exercises are done up to 3 times a day for 20 minutes. So this picture shows the basic Kegel's exercise and their benefits. And then the indications for the Kegel's exercise also mentioned in this picture. And then what is the normal position that women has to sit? So Kegel's exercise, there is no strict schedule that they have to do it here or there. Whenever they are feel free, any place they can do these exercises. So they must know the 4 facts about the Kegel's exercise. It is commonly prescribed to improve the many conditions. It will strengthen the pelvic floor muscles and it lift the pelvic floor and contract the muscles, thereby they give strength to the muscles in that particular area. It can be done at any locations, at a home or office or in any places wherever they feel comfortable. And it has been proven effective in reducing the urinary incontinence. So if you are seeing the benefits of the Kegel's exercise, the first and foremost will be the improve the sexual response and the functions, then recover from the physical stress of the childbirth, prevention and the treatment of the urinary stress incontinence, and then increase the thickness of the vaginal wall and lubrication of the menopause, restoration of the vaginal muscle tone and improve the vaginal health. So increases the blood flow and nerve supply to the pelvic region, strengthen the pubocarcageous muscles. So these are the common benefits of the Kegel's exercise. So we have to emphasize the importance and the benefits of the Kegel's exercise to the female client. Then pessary treatment. In this picture, we can see the different forms. It is a mechanical device for correcting and controlling the UV prolapse. So we have to inform the people. These will not cure the prolapse. Only thing, it will help to keep the genital tract in its normal position. Advice for the patients who cannot undergo the surgery. There are different forms of the ring pessary. Then here will be the Hodge pessary, then Smith pessary, and then result pessary. These are all the different forms of the pessary available. Common ring type they are using. Then Hodge pessary they are using. Then indications during pregnancy, first trimester, during puerperium and unfit for the surgical treatment. So when they're selecting that pessary, it is depends on the patient choice. Whichever they want, they feel comfortable, that can be selected. Then management, choice of the pessary commonly used. Size depends upon the size of the vagina. Sterilization, then insertion. Before insertion, the pessary is kept in a hot water for a few minutes so that the pessary will become soft and easy to insert. Follow-up is very essential. How to take care of that pessary, how it has to be removed. Okay, so pessary should be removed, cleaned, and reinserted at regular intervals of up to 6 to 12 months. When you are discussing the surgical treatment, vaginal hysterectomy is the most common operations, and it has been indicated in the following conditions. That is a postmenopausal prolapse, uteropathology like small fibroids or adenomyosis, then menstrual disorders such as a dysfunctional uterine bleeding, then prolapse during the childbearing age, and then after the completion of the family life cycle, then purge operations for relief of symptoms of cystocele. So types of the hysterectomy here, partial, total, and then radical hysterectomy will be carried out. Partial hysterectomy in the sense it removes the 2/3 of the uterus. Then total hysterectomy, that is in glucose, that remove the uterus and the cervix. Radical hysterectomy, it remove the entire uterus, cervix, and the vagina. So pre-operative nursing care to be and post-operative nursing care should be clearly taught to the client. So in pre-operative period, explanation is very important. What is the reason for hysterectomy and what are all the things they has to do and what can be expected during the post-operative, that has to be explained in detail. And then it is usual the patient has to be in NPO minimum 8 hours, 6 to 8 hours from midnight on the night before the surgery and must avoid before the surgery. And enema to be administered before the surgery to evacuate the bowel and prevent the contaminations and trauma during the surgery. So vaginal irrigation is performed before surgery with the normal saline. Skin preparation is done if it is ordered. So in these two methods and the enema and vaginal irrigations, we have to obtain the doctor's order. Some of the doctors, they are not mentioning that enema. So depends on the patient's condition, depends on the type of the surgery. We have to follow the pre-op order very carefully. And then as usual, pre-operative medications should be administered to the people. Then assess the vital signs frequently, that every hour. Then follow that. The patient condition improve, then we can go for the 4 hours like that. It is very meticulous skin care and meticulous observation of the patient to be done. Monitor the intake and output chart, then assess for the complications like infections, pneumonia, hemorrhage, shock, and thrombophlebitis. After 24 hours of post-operative, we have to auscultate the chest for the breathing sound. We have to check the incision site, whether it is clean or whether any bleeding is takes place or not. Like that, it has to be monitored very properly. Then bowel management is very important. Auscultate the bowel sound every 6 to 8 hours by encouraging them to move out of the bed. So ambulation to be encouraged as early as possible. Prevent increase in intra-abdominal pressure, which will cause the bleeding. Avoiding constipations by administering medications like stool softeners, mineral oil, laxatives as indicated in the case. Stool softeners and laxative until peristalsis. So we have to check the peristalsis movement. Then only we have to go for prescribe the administer the stool softeners and laxatives. Food and fluid intake promote the resumption of the normal bowel eliminations. So before doing any thing, we have to check the patient's conditions. Bladder management is playing a major role. We have to know the voiding pattern and we have to monitor the urinary output. So provide a routine voiding measures. It is usually this procedure is followed for most of the patients after the post-operative period. That is in privacy to be given, normal position, running water in the sink, pouring warm water over the perineum, that has to be done for the client. Then encourage a good perineal cleansing and catheter care to reduce the risk of ascending urinary tract infections. In vaginal packing removal after 24 hours, then apply dry heat to promote the healing process. Patient should be kept in a supine position and avoid high bolus position because the pressure under the knees or crossing of the legs will lead to other complications. It creates a vascular stasis by increasing the pelvic congestions and pulling of blood in the extremities. That will potentiate the risk of thrombus formations. Then dietary need is another important one. We have to give you a food high in protein and iron for the easy healing of the wound and then betterment of the patient's conditions. Facilitate the healing and the tissue regeneration helps to correct anemia if it is there. Then ensure that the patient turn, cough, and deep breathing at least every 2 hours to aid in the respiratory exhaustion and to prevent the stasis. And then we have to teach and demonstrate the patient how to use the pillow over the abdominal sutures to aid the abdominal muscles and decrease the pressure associated with the coughing. And then keep the patients in a low follows position or flat position to prevent increased intra-abdominal pressure. If it is there, if it is an increased intra-abdominal pressure, that also will lead to the complications. So avoid placing the client in high follows position and placing under the placing a pillow pressure under the knees to prevent the stasis and pulling of blood in the extremities. Avoid sitting with the knee bend and crossing leg. These are all the general, these things are very simple, but we have to explain to the patient clearly. Apply the anti-embolic stockings and assist in passive and exercise at least every 4 hours to enhance circulations and aid in the venous return. So encourage ambulation as soon as possible. Thereby the patient's condition will be improving. To promote the blood circulation, we have to encourage the patient to go for early ambulations. And as it is possible, we have to promote the micturations at regular intervals when the catheter is removed. Then check for the hormone sign. It is a common one. We have to check for the patient. That is a cough, tenderness or pain at least once, or a shift to assess for the thrombophlebitis. That is also another complications will happen that we have to monitor. Change a perineal fan as needed. Observe the vaginal discharges, and then a detailed note has to be taken regarding the color, amount, and the order. Then administer the antibiotic HRT as ordered. Hormone replacement therapy. Assess the dressing for the sign of bleeding and the infections. There are certain procedure that keeps the uterus in the place, that is called as a uterus sparing procedure. These surgeries are for the people who might want to have another pregnancy. So here regarding this, very less information is available, but we will be discussing what are all the types of the surgeries are there. First one will be the use stitches to fix weak pelvic floor structures. So this can be done in a way that keeps the depth and the width of the vagina intact for the normal sexual functions. Then closing the opening of the vagina, that is called colpoclesis. It may allow for the easier recovery from the surgery. That is an option for those who no longer want to use the vaginal canal for the sexual act. Then place a piece of a mesh to support the vaginal tissues. So in this procedure, vaginal tissues are suspended from the tailbone by using a synthetic mesh material. They're providing an extra support. Then anterior colporrhaphy for anterior vaginal wall prolapse, then posterior colporrhaphy for the repair of the posterior vaginal wall and the perineum. Then commonly Manchester operations or Kudrskill operation. It is a repair of the uterovaginal wall prolapse carried out in the women of the childbearing age and haven't completed their families and insist on the preservation of the uterus. This picture shows the Manchester operations, or we can call it as a Kudrskill operation technique commonly used in case of a gynecological surgery for the uterine prolapse. Here there will be fixation of the cardinal ligaments. It purpose to reduce the cystourethral and reposition the uterus within the pelvis. These are all the area they are providing the support to have a clear visualization of the area. Then complications during operations, post-operative and the late. These three things are we have to see. So during operations, it is common bleeding will be the injury. Here in case of the prolapse, injury to the bladder and the rectum. That is a common complication. Post-operatively, retention of the urinary cystitis, hemorrhage, primary or secondary, then infections. Then late, if you are seeing, that is a dyspareunia, cervical stenosis, hematometra, infertility, cervical incompetency, cervical dystocia in labor. These are the common complications occur during the operations, post-operative and the late period also. And then if you are seeing the characteristic of the enhanced recovery pathway in robotic hysterectomy, here the preoperative care, intraoperative care, postoperative care that has been given in short form. Preoperatively, it is as usual NPO, bowel preparation. Some of the doctors will be prescribing, some of them not prescribing. That we have to be very clear. We have to follow the pre-op order. And then antibiotic medication, as usual, it has to be given as per the doctor's order. Intraoperative period, intraoperative mechanical thromboprophylaxis, maintenance of the normothermia, avoidance of the nasogastric tubes or the abdominal drains, minimal blood loss will be there, use of local anesthetic, keyhole closure. Then in the postoperative period, this is usual antiemetics to be given and analgesics as per the patient's conditions. Then education of the relatives in the pain and the wound care is very important. Then decreased use of the regular opiates as a painkillers and laxatives. Quick complete ambulation is another one to promote the circulations. Then post-operative thromboprophylaxis also to be given. So all the surgeries will have the risk. The risk of surgery for uterine prolapse include heavy bleeding, blood clots in the legs or lungs, infections, a bad reaction to the anesthesia, injury to the other organs including the bladder, ureters and the bowel. Prolapse may happen sometime So repetition we can expect in some cases, the urinary incontinence. These are all the common complications we can see in case of a prolapse. Another complications, anterior prolapse. So results from the weak connective tissue between the bladder and the roof of the vagina that can cause the bladder to bulge in the vagina. That is called as cystocele prolapse of bladder. Posterior rectum is situated. So weak connective tissue between the rectum and the floor of the vagina that cause the rectum to bulge into the vagina. So these may cause a difficulty with the bowel movements. Posterior vaginal prolapse is called as a rectocele. So discharge education. So during the hospital period, anyway, the healthcare people are there, they will be taking care of the patients. But the discharge education is another key role where the proper education should be given to the people what they has to follow in the home. That we have to be explained clearly. So here in the discharge education, instruct here to ambulate at regular intervals, avoid sitting for a prolonged at home or when traveling because of the possibility of blood pooling in the lower extremities, which increase the risk of thromboembolism, increases the intra-abdominal pressure to increase the stress on the wound. Instruct here to care for the incision site and teach the sign of the infection as redness, swelling, pain, discharge, or increase in the vaginal drainage fold order. Then as usual, 3 balanced nutritious diet has to be taken and adequate intake of water, minimally 6 to 8 glass of water to be taken. And then avoid heavy lifting and vigorous activity for 6 weeks after the surgery. We have to get a specific instruction from the doctors. Then avoid a situation low self-esteem. That is a common scene among the most of the post-operative clients. So development of negative perception of the self-worth that increase the response to current situation. So we have to listen their concerns, fears and worries, how it can be cope up, how it can be rectified. Alternative measures we have to explain to the client. Explain to avoid constipation, training a test stool, and then avoid sexual intercourse for up to 4 to 6 weeks as indicated by the doctors. Discuss the changes regarding the changes in the sexual function, such as shortened vagina and possible dyspareunia because of dryness, and offer suggestions for alternatively for use of water-soluble jelly also. Avoid douching, tampons, and anything in the vagina for 4 to 6 weeks as indicated by the physician. Follow up maintaining the regular gynecological examinations. To conclude this topic, uterine prolapse is another common conditions occurring in the women of irrespective of any ages. Then we had discussed regarding the definitions of meaning, then the risk factor, causes, and then types, and then the common signs and symptoms, pathophysiology, and then diagnostic measures, and then complications, and what are all the medical and what are all the alternative measures and can be given for this type of the uterine prolapse. And then post-operatively, pre-operatively, what are the care can be given to the patient, that and all we discussed in detail. I hope this topic will be very useful for you. I thank each and everyone for your patient listening. These are all the books.